So esophageal atresia and tracheoesophageal fistula. Here we are going to talk about pathophysiology, risk factors, signs, symptoms, diagnostic and treatment, and nursing care plan. In this picture, we can see this is the esophagus, and esophagus is continued to the stomach. When we eat something, food directly go to esophagus to stomach. It is the normal anatomy. But in this picture, we can see the esophagus not continue to the stomach, and esophagus is stopped, and this is called atresia developed. And the lower part of esophagus continue to the trachea and formation fistula. In this picture, we can see different esophageal atresia and tracheoesophageal fistula, because trachea continued to the esophagus and formation tracheoesophageal fistula. So first of all, it is esophageal atresia. It is the congenital medical condition, or we can say the birth defect, and that affect the alimentary tract. It causes the esophagus to end in a blunt-ended, like this picture, blunt-ended. This picture, blunt-ended. And also pouch rather than connected normally to the stomach. It comprises a variety of congenital anatomic defects that are caused by an abnormal embryological development of esophagus. Another keyword is tracheoesophageal fistula. It is commonly a birth defect with the trachea connected to the esophagus, like this picture, trachea connected to esophagus. Third picture, trachea connected to esophagus. Last picture, trachea connected to esophagus. So trachea connected to esophagus, in most cases, the esophagus is discontinued and causing immediate the feeding difficulties. And tracheoesophageal fistula may develop in adult life or secondary to invasion of the cancer in this area. So let me read it. The esophagus terminates before it reaches to the stomach, or ending in a blind pouch, and or a fistula is present that forms an unnatural connection with the trachea. So it is abnormal, right? It's supposed to connect to the esophagus, but if it is connected to the trachea, abnormal pathway formation we call fistula. And this condition causes the oral intake of enter the lungs or a large amount of air to enter the stomach. And choking, coughing, and severe abdominal distension can occur. Aspiration pneumonia and severe respiratory distress will develop, and death will occur without surgical intervention. So it is the birth defect that causes the malformation of esophagus and trachea, and causing the high risks of aspiration pneumonia and respiratory distress. So they said the treatment include maintenance of a patent airway, prevent of pneumonia, gastric or blind pouch decompressions, supportive therapy, and surgical repair. What else? So in this picture, the first picture, normal anatomy, esophagus continued to the stomach, and trachea, this is the respiratory tract, this is the gastrointestinal tract. But in this picture, we can see atresia develop. The esophagus does not continue to the stomach. And this picture, not only this esophagus formation abnormal tract to the trachea, and this is the upper portion from the trachea. Here we can see the lower part of esophagus forms a abnormal tract with trachea. So food chance to go to the lungs and air comes to the GIT. So congenital atresia of esophagus and tracheoesophageal fistula. Picture A, upper and lower segment of esophagus end in blunt sac. Picture B, upper segment of esophagus end in atresia and connect to the trachea by fistula tract. Picture C, upper segment of esophagus end in a blind pouch. Lower segment connect with trachea by small fistula tract. So esophageal atresia, the pathology. The upper esophagus does not connect to lower esophagus and stomach. And tracheoesophageal means esophagus and trachea are abnormally connected. Right? Same picture. And here we can see a little bit complex. It is esophagus connected to the stomach and same time formation fistula. Right? So food go to the tract, respiratory tract. So picture number D and E, congenital atresia of esophagus and tracheoesophageal fistula. Both segments of esophagus connected by fistula tract to trachea. And picture E, esophagus is continuous but connected fistula tract. Fistula means abnormal pathway. So it is esophagus and trachea are abnormally connected and formation of the fistula. So what are the risk factors? Particularly polyhydramnions means excessive amniotic fluid during the pregnancy or with a prenatal ultrasound. So data collection, sign symptom, usually easy to remember, 3 C's like coughing, choking, and cyanosis. So choking, respiratory distress during the feeding. And when respiratory distress, it leads to the cyanosis, means lack of oxygen to the tissue. Also, abdominal distension, right? And I said reflex is coughing. So what else? The regurgitations and vomiting, abdominal distension, increased respiratory distress during and after feeding. Preoperative intervention. If patient have esophageal atresia or tracheoesophageal fistula, we diagnose by chest X-ray or bronchoscopy. And treatment management is surgical repair. So we have to know what are the pre-procedure and post-procedure. Preoperative intervention, the infant may be placed in a radiant warmer in which the humidified oxygen is administered. Intubation and mechanical ventilation may be necessary if respiratory distress occurs. Maintain nothing by mouth status, maintain IV fluid, and suction accumulate secretion from mouth and pharynx. Maintain in a supine upright positions, at least 30-degree upright. to facilitate drainage and prevent aspiration of gastric secretion. So next is preoperative intervention. The blind pouch is kept empty of secretion by intermittent or continuous secretion as prescribed. If gastrostomy tube is inserted, it may be left open so the air entering to the stomach through the fistula can escape. Also, broad-spectrum antibiotics may be prescribed because of high risks of aspiration pneumonia. What next? The post-operative intervention basically monitor the vital sign and respiratory status, assist in maintaining IV fluid, antibiotics, also parenteral nutrition, monitor strict input and output, monitor daily weight, monitor for dehydrations and possible fluid overload, monitor for sign of plain, and assist to maintain chest tube patency. Inspect the surgical site for sign and symptom of infection. What else? Monitor for anastomic leaks as evidenced by purulent drainage from chest tube. If a gastrostomy tube is placed, it is usually attached to gravity drain until the infant can tolerate feedings and anastomosis is healed. Before oral feeding and remove of the chest tube, assist to prepare for esophageal as prescribed. Before feeding, the gastrostomy tube is elevated and secure above the level of stomach to allow the gastric secretion to pass to the duodenum and so swallowed air to escape through the open gastrostomy tube. Assist to administer oral feeding and check the cervical esophagostomy site if present for redness, breakdown, or exudate. We remove accumulate drains frequently. Apply protective ointment or barrier dressing and or collect the device as prescribed. We assist to provide non-nutritious suctioning using a specifier for infant who remain nothing by mouth. Re-educate, instruct to the parents in techniques of suctioning, gastrostomy tube care, and feeding. Also, skin site care is important. Re-educate or reinforce instruction to the parents to identify behavior that indicate the need for suctioning, sign of respiratory distress, and sign of constructed esophagus, like poor feeding, dysphagia, drooling, cough during feeding, or regurgitate or undigested food.